Welcome to the Medical Ancillary Sales Podcast, your number one source for making money in the medical ancillary sector. Mike and Viv bring you the latest information from lab services, pharmacy, diagnostic testing, and so much more. The latest in ancillary services will be right around the corner. Welcoming the hosts of the Medical Ancillary Sales Podcast, here's Mike and Viv.
Hello and welcome to the Medical Ancillary Sales Podcast. I'm Mike Berg and I'm flying solo today. I have a special guest with us, Mr. Shad Sherwood from Imperium. Shad, how you doing?
I'm good, Mike. How are you?
I'm great. Thanks for joining us. Let's jump right into it. We've had a lot of interest so far on the genetic carrier screen, and I know you are the expert. And you and I had a conversation about a week ago, and I thought, geez, Shad, please, can you get on this podcast? Because I think what people are looking for are some good sales techniques and some things to tell doctors as they get out there in the field. So I just want to put you on the spot a little bit, and first and foremost, can you break down how you pitched this and your team pitches this to doctors?
Yeah, sure, no problem. Paul, thanks for having me on here. The way to pitch this really is it's not too much of a quote unquote pitch, if you will. This test in particular, out of all the different lab services that I work with, is the one that's easiest to prove the medical necessity behind it. And so it's not about going in there and trying to convince a doctor necessarily on cramming a test down the patient's throat or what have you. It's more of an elective test, but it's important for the physician to understand that the need for the test and the breakthrough, I guess, in science and in genetic testing, to where now this is an opportunity for their patients to be able to see if they are a carrier for a number of different gene mutations that could cause them to have a child with one of these over 60 different rare diseases like cystic fibrosis and Tay-Sachs and things like that. So really, it's all about the physician being able to provide the service to the patient. In looking out for their best care. So really, when it's talking to a physician, it's just along the lines of educating them on this test, that it's available, and then just finding out of their patients, just maybe on the intake, to see which ones fall into the reproductive age category, which is anybody between 18 and 45 years old. Now, those can be approved if they're above 45 years old, just kind of depends, but that's really the sweet spot. And then if they could possibly have a child one day, right, whether they're planning on it, whether they're pregnant, they're going to do it in a month, 2 months, or even 15, 20 years down the line. If there's a possibility they're not fixed, if you will, they are capable of having a child, and they could have a child. Those two criteria that creates the medical necessity behind it. So at the very least, the doctor just needs to at least find out if they fit that criteria and offer them the test. If they want to do the test, they do it. If they don't, then they don't. But at least the doctor can do is, at the very least, what they can do is offer the test to the patient and let that patient decide on what they want to do. And I think you'll find that the greater majority of them want to do the test to find out the results.
What about me as a male? Could I go in, or do I have to have my significant other take the test first before I can get that covered?
No, you can actually go in there and get the test done. It's going to be the female first, but if you wanted to go in there and get the test done with the physician, you fit it's medically necessary for you too, using the same criteria I just talked about, most definitely. Now, if it comes back and you or your significant other are a carrier, then the other one definitely has to get tested, because it really doesn't do any good if just one of you are tested, right? So it takes both of you to be a carrier, to put you at that risk of having a 25% chance or a 1 in 4 chance of having a child with one of these rare diseases. So, but if you want to go in there and just do it first, that is completely up to you.
I'm thinking, because I could get the results and I could put that up on my Tinder profile, and that would attract women. Say, hey, he's not carrying anything. What do you think?
That's exactly right. That's a huge bonus. I mean, I would do the same exact thing, because I know before, some women out there might look into that, and they'd probably just ask them out on a first date to see if they're a carrier, and if not, they just go ahead and swab their mouth.
There you go. So, okay, This is the feedback though that I think we're already getting this from some physicians. Some doctors are a little gun shy because when they hear any sort of genetic testing, be it cancer screens or pharmacogenetics, you're getting spotty insurance coverage. Some patients are covered, some aren't, and you get some patients that are stuck with large out-of-network bills. Can you address that?
Yeah, no problem. Yeah, I know that's news to me. What we've seen with this test is it actually reimburses at a higher adjudication rate than anything else, even higher than blood. That from what we've seen out there. So yeah, it's a genetic test, but when it comes down to it, insurance views this one in particular, the carrier screen, as very medically necessary, right? So they see this as very, higher on the list of medical necessity than like PGX testing or maybe even the cancer, the hereditary cancer and things like that. Just because, as an example, you take cystic fibrosis as an example. If you have a child that has cystic fibrosis, it actually costs insurance between $54 and $75,000 per year every year to treat that as an infant all the way up to the average lifespan of 38 years old. So obviously a substantial amount of money that would fall on to that insurance carrier if, of course, that insurance sustained throughout that amount of time. For them to pay $4,000, $5,000, up to $15,000 for that test, for that couple to be able to make a decision on whether they don't have a child at all, maybe they get an egg and a sperm donor, maybe they adopt, is worth it for them to pay for that test. So they're hoping that they will make a decision along those lines. I've seen personally on different reports. Now HMO plans are not reimbursing well. So we're talking about PPO plans that are the primary ones. But if they fit into that category, and the bottom line is, if you have an insurance company and you're contracted with them and you're paying them, your company's paying them or you're paying them, right? It's in your contract that they will cover, certain tests, and they have all the criteria. If you just simply Google genetic carrier screening and then put and BCBS or and United Healthcare, whatever the case may be, you'll find it right in their policy of what their criteria are. And it seems like on their what I read on there, they're going through. They're not as in real life. They're not as strict as they read on there, but it clearly states in there the ones that are covered and are approved. So that being said, just the numbers don't lie as far as the number of them going through. The percentages that I see are at the very top of the food chain. That unless you got a bunch of HMOs up into 90% and stuff like that. So
and you guys, you have an extra layer of protection too. You're not just jamming these claims through. You're pre-adjudicating these, right?
We do. Yeah, we our billing department is going to pre-verify every single one of the claims that comes in. This is an expensive test to run, right? So we don't want to just go ahead and test all of them and then just and see if it's going to get approved or not. So we're going to run it through there and see if it's pre-verified. And so they'll tell us, no, there's no way we're going to cover this test, or they'll say yes. Now, if they say yes, does it mean they always do? No, but most of the time they do. So that being said, that's going to prevent us from wasting any money on the test. And of course, we're not going to test it. They don't cover it and slap the patient with the bill. If it's not covered, the lab will call the patient and tell them that your insurance isn't going to cover this. Here's our cash price, and then they'll offer that to them. And so then it's up to the patient whether they want to move forward with that or not. So, that, and then we also have in-network. We have a choice of in-network or out-of-network billing. So if you have a patient that on their insurance plan they have both in-network and out-of-network billing on their policy, we're going to verify and check the insurance as well and see which plan is the best one to bill it out through in that regard. So if their deductible happens to be lower out-of-network than it is in-network for whatever reason, then that's the route we're going to bill, because that's going to be most advantageous for the patient, obviously for the physician, and then and obviously for the lab and the rep and everybody else. If they have a high deductible and they don't have the out-of-network benefits, then they're going to go ahead and bill it in-network. So that increases our adjudications as well above the other laboratories out there.
And I also noticed something I was reading is ACOG, as part of their guidelines, they actually recommend this test. So I don't know how much that helps you in the primary care space, but I would think that it definitely couldn't hurt. But definitely anyone who's doing women's health, I think it's a simple question. Do you follow ACOG guidelines when it comes to genetic carrier screens? And I'm sure a lot of them will look at you sideways because they're maybe not aware of this screening tool. But you can look on that's the American College of Obstetricians and Gynecologists, and you can just do a quick Google search of the genetic carrier screen and ACOG, and it's pretty simple, one line, that they recommend this as a screening tool.
Absolutely. Yeah, no, it's right there. As a matter of fact, I was just looking on the Blue Cross Blue Shield policies, and they actually stated on their policy that as far as the ACOG, they said, I'm looking at it right now, as a matter of fact, that they reconfirmed that in 2013. It came out 2004 and reconfirmed in 2013, used a 23 mutation panel. So most definitely. So what you're going to find is your OBGYNs of the world or anybody in women's health, they're already going to be doing some form or fashion of a cystic fibrosis test, some sort of carrier screen. A lot of them are going to be doing cystic fibrosis, period. Obviously your selling point in going in there and talking with them is, you already know they're doing it. If they're not doing the cystic fibrosis test, well, they're really not doing their job, obviously. I mean, ACOG right here is suggesting that everybody get tested. But, why would a physician, if there's 63 genes that you can test for all sorts of different rare diseases, Tay-Sachs, sickle cell. I mean, there's other ones besides just cystic out there that are just as damning to an infant and to any human out there. Why would you choose a test and just do cystic fibrosis when with the same, the same test or the same swab or draw of blood? I mean, of course, we do use a mouthwash and use saliva, but some other ones use a blood draw, and those are the easiest accounts to close. But you could very easily, ask the doctor, so, well, you're testing for cystic fibrosis. What's preventing you from going ahead and testing for all these other diseases that deemed to be medically necessary that are just as harmful for your patient? So they kind of make them feel a little silly in that regard, but a lot of them don't have the means to be able to do that. If you're looking for some low-hanging fruit, in my personal experience and opinion, I would have my guys go out there and look for anybody who's doing this test, which is as far as a rare disease, cystic fibrosis, and see which ones are doing it with a blood draw, which is going to be a lot of them out there. It's very easy to get a physician to use this because we are using a mouthwash scope. As a matter of fact, it's a very simple process, and so to do that instead of using a blood draw is obviously very attractive. Not only for the doctor to not have the phlebotomist, get involved, draw the blood, maybe have to redraw it, but also for the patient. Nobody likes to have a needle in their arm. So I call that the low-hanging fruit, most definitely. And if you just want to focus on that to land some quick accounts, no doubt about it, you can land those if you hit enough doors.
Well, you said it, Chad. Well, hey, I want to thank you for getting on, and this is great information. Guys, if you have any questions, please reach out to me. You know where to get me. You can email our podcast at ancillarypodcast@gmail.com. Chad, thanks a lot for getting on.
Thank you, Mike.